emphasis of this particular meeting will be on home births, and we will be happy to hear testimonies from those persons who have identified themselves that would like to speak. One thing I like to say is I like to thank my co-chair, Ms. Stephanie Stuckey Benefield, for the work that she's done. Let's give her a hand. I would also like to acknowledge our committee member, Sister Nasra Smith, for her work as well. I always want to call her another last name, but I also would like to thank the work that's been done by our other committee member, Ms. Debbie Pulley. And I want all of y'all to thank me for the work I've been doing. I'm able to make a time. All right, but really, I'm glad that you're here, and I really do appreciate the type of participation we've had. I actually have made a request, and I would like y'all to know this. I made a request that we try to get some press in here, because what we want to do is to make sure that the press and the media does know that we're meeting, but also that we're committed. And we did have an opportunity in February of this year to have a policy briefing, and they did a good newspaper article on us, and we want to try to follow up, and so that gives us momentum as we go into the session. Little housekeeping is like when you go to the microphone, you know, you just, like when you get ready to speak, you turn it on, and then, you know, because last week all the mics was on at all the time. So that means anything that was said was kind of going through those are cameras, y'all. So we are on candid camera.
We're on the internet.
On the internet, so people are watching you. So if you want to act out, it's fine. All right, but
supposed to get an email.
Yes, and also we have some people who have signed in. Some people who signed in did not put their email, and then there are some people who called in to Miss Sally Fox. Will you raise your hand? Our research person, and then in that case, you probably did give her an email, but we want to make sure we have a way to continue to communicate with you as we go forth in this particular.
I'll put this up here.
Yeah. Okay.
And if you want to speak and have not signed the sheet, please sign it.
Yeah.
This is for people who want to speak.
And we're going to give you 2 minutes. 2 minutes to speak, and then, and so we do appreciate it. Just so people, everybody gets speaking. If we got some more time, we'll run back around again. All right. But the first presenter today will be Mrs. Claire Westall, certified nurse midwife, master public health, director nurse midwifery. She's department, obviously you see it at GYNOB, but she also is at Emory as well as at Grady. So she has a wealth of experience, and so what we'd like to do is to ask her to come at this time and give her presentation. Thank you. Let's receive her. Yeah, turn it on.
Good morning.
Good morning.
My name is Claire Westall, and you heard my credentials, but my other credentials are that I'll just tell you a little bit about myself. I became a nurse midwife, I became a nurse in the 60s. I became a nurse midwife in the 70s, in what I might call the good old days when there was a birth culture revolution going on, and I became a midwife in the sweeping day when culture was sweeping women. Or women were sweeping culture to hear their needs and address their issues for normal birth and birth with their families there, and no separation of mothers and babies, and all those wonderful things that we hope for with birth. I had my own 2 children at home in the 70s, one in the 70s and one in the 80s. I understand and hear what I've been hearing and what I've heard in the last 2 hearings that I've been here at the legislature. So I'm real glad to be able to share something about nurse midwifery. I thought that anyone who was studying midwifery also has to know something about nurse midwifery, and so I did volunteer to present this information about nurse midwifery for consideration. Nurse midwife means midwife means with woman, as you all know, and nurse midwife has been educated in 2 disciplines: the discipline of nursing and midwifery. a nurse midwife, a certified nurse midwife, has graduated from an accredited ACNM program and is certified by ACNM or the American Midwifery Certification Board, AMCB. We believe in prevention and education. Pregnancy and birth is normal. We provide compassionate care, family-centered, that's culturally appropriate. We encourage women's participation, and we use technology in the interventions appropriately with decisions made on an individual basis. And as I continue my talk, you'll recognize that that's the ideal description of the philosophy of nurse midwifery care. The American College of Nurse Midwives, I am a board member on the American College of Nurse Midwives. That organization is the professional organization for nurse midwives in the United States and sets the standards for the practice of nurse midwifery, establishes core competencies, the core skills and knowledge that a nurse midwife must have for practice. We have peer review, a code of ethics, and we produce clinical bulletins as that's part of what we do. The founder of nurse midwifery, the founding mother of nurse midwifery in the United States is Mary Breckenridge. She, in 1925, she was in the eastern Kentucky Appalachian mountains, and she was a British-trained midwife, and she was committed to take American public health nurses and have them trained as midwives in England and have them come back to provide primary care to the poor Appalachian women in Kentucky. So this was the first model of nurse midwifery care as primary caregivers and home birth, obviously, the midwives on horseback, and was the first demonstration that nurse midwifery care can make a huge difference in maternal and fetal and newborn and neonatal outcomes. The history of nurse midwifery in Georgia is very interesting. I was able to do a little bit of research on this in preparation for this talk. In 1946 to 1955, there were 2 nurse midwives who were hired by the Department of Health, and they were brought in to supervise and train and teach the lay midwives, the granny midwives, and to establish demonstration projects for nurse midwifery care and to develop teaching materials. And they did develop a handbook for women about pregnancy and the hygiene of pregnancy. They did develop teaching materials for midwives. They had some demonstration projects. One in Thomas County, they had a home delivery service. In Walton County, they had a hospital service where they assisted private physicians and gave maternity care in the health departments. They also made home visits. In Lamar County, the nurse midwives had a 10-bed maternity shelter, which I guess you might call an out-of-hospital birth center, where a nurse midwife was present 24 hours a day to receive the women who needed to come there. And one remarkable product of this time that still remains is the film All My Babies, which was a teaching film that have you seen that movie? It did come out of this period of time, and it was an instruction teaching tool for the granny midwives. In I meant to move that. I moved it on mine and didn't move it on yours. I'm jumping ahead to 1976. I'm going to go back to that slide. In 1971, the Grady Nurse Midwifery Service was started. That's the service that I'm the director of now. There was no law that explicitly allowed nurse midwives to practice in the state of Georgia, but there was a joint practice statement, which was an agreement between physicians, the obstetric service, and the nursing service, that an agreement about how nurse midwives would be used and would practice. In 1972, the M&I project, the M&I Council, Maternal and Infant Council, was established to advise the Department of Health and the agencies of state on all matters pertaining to pertaining to MCH, and I believe the M&I Council still meets. Am I right about that? Yes, there is still an M&I Council. In 1972 to 1975, there was an acute shortage of obstetricians throughout the state, and there was, again, state support for nurse midwifery projects, one notable one in the Glen Brunswick Hospital. And in 1973, a nurse midwifery program was state-funded in Thomasville, and that practice is still existing. Now I'm going to go back. In 76, you can see that there's a growth of nurse midwifery throughout that period of time in Georgia, and the truth is it was as the nurse midwifery grew and was supported, then the granny and lay midwifery practitioners were decreased in importance, so that kind of converged in 1976 when the Division of Physical Health said there would be no new certifications for lay midwifery. Yes, it was called the Division of Physical Health at that time, yes. According to my history, my studies, whoops.
You're going next.
In 1977, the first nurse midwifery specialty education program was established at Emory University in the School of Nursing, and all of their clinical experience was at the nurse midwifery service at Grady Hospital. In the 80s, there have been expansions of nurse midwifery programs throughout the state to increase the availability of maternity care to indigent and medically underserved women. Again, state supported. In 1984, the Nurse Practice Act adopted rules for certified nurse midwives, so this was the first explicit Nurse Practice Act revision for nurse midwifery. And in 1994, it's changed again, but generally the definition of a nurse midwife is the independent management of the care of the essentially normal newborn and women for antepartum, interpartum, postpartum, and gynecology. These are very key things I'm going to say now. The CNM must practice in accordance with the current standards as established by the American College of Nurse Midwives. The practice of nurse midwifery occurs within a healthcare system which provides for medical consultation, collaborative management, and referral. So the key description of where we sit right now in the state of Georgia has to do with our requirement for collaboration, consultation, and referral of physicians. The number of nurse midwifery deliveries nationally, it's 10.7% of the vaginal births in the United States. In 2004, you can see here, this is the latest data. There was the first real drop in numbers, although the percentage stayed pretty close to the 10.7, and that's attributed to the increasing cesarean section rate. So actually the number of vaginal births have gone down. So we still can maintain 10.7, but the actual raw number has gone down. Oops. Okay. The percentage of vaginal births by nurse midwives in Georgia, 23.7% in 2004. So we deliver almost 1 out of 4 vaginal births in the state of Georgia. You can see compared to where we were in 1990, 2000, 2004. So nurse midwives have a very strong presence in Georgia, and we're actually have one of all the states in the United States, we have one of the highest percentages of vaginal birth deliveries. Again, our relationship with physicians is collaborative. We have consultation, collaboration, and referral, so we are required to retain that relationship with physicians. There are joint statements between the American College of Nurse Midwives and ACOG, which is the American College of Obstetrics and Gynecology, and these joint statements have been changed over time. The latest one, ACOG and ACNM affirm their commitment to promote appropriate standards for education and certification of their respective members. to support appropriate practice guidelines and to facilitate communication and collegial relationships between OBGYNs and nurse midwives. Nurse Midwifery Education, there are currently 41 ACNM accredited programs. The majority are at the master's level. Most are in schools of nursing, some in schools of public health, some in schools of medicine. We anticipate over 350 graduates per year. And the American College of Nurse Midwives does educate and our certified direct entry, our direct entry midwife, which is a certified midwife. This is a professionally educated midwife who's not educated as a nurse, but she does, the education is comparable to the nurse midwifery curriculum, and she sits the same certification exam as a CNM. CMs can practice in 3 states, not Georgia. If you think back to the map that was shown the first day, there were a couple little gray states up there. New York and Rhode Island and New Jersey are the 3 states where certified midwives can practice. There are about 50 or 60 certified midwives in the United States. So again, that is ACNM's direct entry midwife program. The scope of practice is that midwives do more than deliver babies. We also give primary care. We're primary care providers. And past the basic core competencies, nurse midwives can advance their clinical practice to include first assist at cesarean sections, colposcopy, circumcision, and ultrasonography. The site of birth, the American College of Nurse Midwives supports home birth. However, you can see in the United States that 96% of nurse midwives deliver babies in the hospitals, couple percent in out-of-hospital birth centers, and less than 1% at home, attended by certified nurse midwives. So I think that what I'd like to be heard very strongly is that certified nurse midwives do not meet the demand and the need for home birth in the United States or in Georgia. I put 100% of births in the hospital in Georgia. There might be a few that occur in birth centers or out of home, but essentially 99.9% of nurse midwives' births in Georgia are in the hospital. We practice in hospitals, health maintenance organizations, community-based family practice, physician practice, nurse midwife practices, birth center, and military. So we're quite widespread throughout the organized health system. And we do have a credential, licensure, national certification. You graduate from an accredited program, become certified, get state licensure. In Georgia, we also have to be, our authority comes through the Nurse Practice Act. That's true in about 35 or 36 states where nurse midwifery is linked to the Nurse Practice Act. We have to have professional liability insurance. We maintain our continuing competency, and then we have to meet agency-specific requirements, being credentialed at hospitals mostly as associate medical staff or allied health staff. There are lots of studies that report nurse midwifery outcomes. They've been published in very prestigious journals. I'll just go over some of these. The Journal of Epidemiology and Community Health compared to physicians. This was an interesting retrospective study, birth certificate data that controlled for risk, and it showed that nurse midwives have less infant mortality, less fetal distress, and less low birth weight compared to physicians.
Did you say that again?
I can give you that source.
It's on your thing.
I wasn't reading that. Did you say that again? I can't remember what you said.
Oh, yes. Retrospective study of birth certificate data, and they controlled for risk. So they controlled for the risk and then looked at the outcomes. And the nurse midwives had improved outcomes in those 3 areas that I mentioned. There's another study in the Journal of Public Health, again compared to physicians, that the conclusion of this is that we use technology in birth interventions appropriately. Continuous electronic fetal monitoring, close to 100% with physicians, but, I mean, I guess over 60%, but 45% with nurse midwives. The New England Journal of Medicine and American Journal of Public Health studied how effective nurse midwives are with labor support, and we have use ambulation, intermittent monitoring, 3 times more unmedicated birth, half as many episiotomies, and support during labor is continuing presence, coaching, water therapy, alternative birth positions. Prenatal care contributes to excellent outcomes. Again, a prestigious journal of epidemiology, and that compared to the content of the nurse midwifery care includes lifestyle advice, emotional support, pregnancy and birth education, lab tests, and medical interventions. Women prefer practices with nurse midwives. Again, were they satisfied, and would they use again in practices with nurse midwives? They're more satisfied and would use it more. That's interesting.
Yeah, it is. Close that whole window.
I must have clicked on the wrong thing here. I clicked on the graph. Nope. Again, specifically to Georgia, there are over 90 nurse midwifery practices in Georgia. Most of the nurse midwives are employed, work in private practices, HMOs, universities, and hospitals. Our issues for practice and things that we believe constrain our practice are things you've heard before, and that is we have a hard time. We're required to have liability insurance, and the availability of liability insurance and the price is puts a lot of pressures on our practices, and actually practices are closing because of the increased cost of liability insurance. We have, American College of Nurse Midwives has an insurance carrier that provides liability insurance to nurse midwives who are doing home birth. It's, I think, the only one that, it's the only insurance company that is insuring home birth for nurse midwives. We have are able to get third-party reimbursement, again at a lower rate than physicians. Other pressures on us is the midwifery model of care versus the medicalization of birth and technology, and we're in the middle of that and struggling with those pressures to maintain nurse midwifery. And I'll just put a little plug in for what's happening to nurse midwives currently. In 2006, we gained prescriptive authority to transmit drug orders in writing, and Georgia's the last state that granted prescriptive authority to advanced practice nurses. And last Friday, the Composite Board of Medical Examiners thwarted the intent of the legislation by issuing rules and regs that require a physician's physical presence and requires a co-signature on medical records, and neither of those things are required for the independent practice of nurse midwifery. So there are many practices who will not be able to take advantage of that authority that we were granted. I think we'll be going back. Yes.
I actually heard that from a nurse midwife about 2 weeks ago that this might happen. So I appreciate the update.
Okay.
Are you contacting your legislators to let them know, because we need to hear about
Yes,
this? We wanted you to have the authority to write prescriptions without onerous restrictions.
I think that there is an organized effort to contact the legislators and to return to the legislature and let them know that their intent was thwarted. Yes. So the culture of midwifery, as you know, is all about listening to women, caring for women, empowering women, and doing the right thing for the future and the future of our children. And I just did want to make sure that you understood that nurse midwives, certified nurse midwives, are here in the state of Georgia, and sympathetic, but within the constraints of our own practice and our own professional identity, are not meeting the need for home birth in the state of Georgia. Yeah, I didn't get that in.
What I'd like to do is to first say really thank you, and we do have some questions, but I want to let the body know that another member of our committee is here. Representative Donna Shelton is here, so I wanted to make sure we all knew that. One thing that just, could you go back to the slide that says the culture of midwifery is all about listening to women? Just leave that up while we're talking. Okay. The concern I have is that even though, okay, one thing, Sally, I need a copy of all the members and any information I can get as far as addresses on the state composite, medical composite board, so I can just see who the membership is and when they rotate off. All right, and then and then the next thing, even being a certified nurse midwife, you're sort of showing us some obstacles that you even run into. All right, my concern is that there's a perception, and maybe a lot of truth to it, maybe too, is that if you have more education around a thing, that makes you more of an expert of the thing. Now, I figured that before we go any further, otherwise we'll just keep on just having meetings. At some point, the room needs to be opened up. Y'all follow me? We need to really discuss some things. We know at some point, as it goes on, Representative, that we'll get to do it. But when I look at what's sort of projected as far as the next agenda days, I see a lot of people presenting again, and we might not have the time. So this might be the meeting that maybe everybody don't speak from the mic like that. But maybe if y'all would allow me, we open this room up and really begin to say what's going on in our hearts and where we're coming from. My perspective on it is this, is that I know that my people, in terms of African American people, have had a legacy of being granny midwives throughout Georgia. It was the only thing we could do. In other words, it was just what it was. It wasn't enough hospitals, and it wasn't enough opportunities for us to have transportation even to get to the nearest hospital. So subsequently, a lot of women have assumed the role of midwives, and they did it so many years that they were actually moved to a status of what we call granny midwives. And there's a whole legacy around it. And NASRA just went out, but there is, and I don't know if Saron or anybody here has it, but there's a program, a conference that happened last year around October. And on the cover of that program, it has like all the granny, not all of them, but like 12 granny midwives, with their bags, and it's just a beautiful picture, and I would love to have that. I'm going to get that picture to y'all projected out, because what I'm saying is, and I listened to your presentation, and you said that basically at one point the nurse midwives and the grannies actually worked together. Did y'all hear that?
Yes.
All right. But then in 1976, because there were more people getting to be a nurse midwife, they stopped certifying. Not that there was something wrong that the midwives or grannies did, but in 1976, when there were more nurse midwives coming on, somebody decided, if they're a nurse, they must be better. They can do a better job, and subsequently they slowed down or stopped the certification of just regular midwives. Okay, here, anybody?
I can't get it on the computer.
Okay.
But I have it.
All right, yeah, but this is a copy of the granny midwives with their bags and everything. Okay, but we're gonna have it projected at the next meeting. But what I'm saying is, so something happened in 1976, and all of a sudden these midwives who had been doing this for all their lives stopped.
And it actually happened before 76. The intent in the 40s was to bring in nurse midwives to professionalize maternity care, and it just took till 76 to do to have the to move enough women into the hospital and to get enough providers so that they then did the act of not certifying anymore lay midwives. In other words, it strategically was planned from the 40s on to move that way.
And in a way, what we do want to do, because there's still a lot of hysterical, and I can't really talk because I don't know nothing about birthing babies besides the fact I've been in a lot of births of babies.
You know what lemons are for?
Yeah, but really, yeah, I do. I've been in a lot of births, okay, with accompanying midwives. And they basically been lay midwives. All right, and I didn't mean to be there. It's just that at the time, they said, come on, and I was there. And so I've been there, What I'm saying is we want a professional. I want to go on record and say we want a professional. We want to be as professional, and we want to be as quality as we can in terms of those persons who are working with our children and bringing our children forth. Okay, that's the bottom line. And at the same time, we got to keep going back to even what the slide said. Birth is a natural process. It is a process, really, to be honest with you, even if the midwife wasn't there, even if the doctor wasn't there, if basically the baby gonna come. The baby gonna come. I mean, it's gonna come, And not that we say that we don't need a doctor and whatever, and all those dynamics, but what we want to be able to at least project, and this is my position, is that it is possible for us to have certified nurse midwives, certified professional midwives. My thought is then there also is certified midwives, CM, which I just found out about. Okay, and I kind of want to know what's the difference between the two? Because
Which two?
CM, certified,
CM,
and the C.
The CM and the CPM basically have the same core competencies in their training. The difference is that the CM program requires a bachelor's degree in anything, and then they go into a university-based setting for the education for midwifery. It was a year,
And they sit they go in.
Right.
The CM goes through a program that's been accredited by the American College of Nurse Midwives, and sits the ACNM exam.
right. Now, the only difference in my mind, this NARM exam is written for out-of-hospital birthing. The CNM exam encompasses woman care and full-scope practice. But the difference is the CPM requires mandatory out-of-hospital births in their training. The CM, in most cases, are hospital-based training. And most of the CMs now are, that's their goal, is they're wanting to practice in the hospital. But we're limited in New York. Many of the CMs were CPMs who couldn't get licensed in New York, who went on to become CMs so they could practice there.
Okay. And so I think some people in the audience might have needed to understand that dynamics, what the difference is. So basically what we got to go forth, we're going to make recommendations. Now, if there is a mood for some people who have particular credentials to say, well, I want to be a certified professional midwife, I want to be recognized in the state of Georgia, then I think that's good. But myself as a committee member is trying to also keep a window open. Yeah,
I just had a question about liability insurance, but we can.
We do. We want to ask that too. But we'll call you because this, if y'all allow me, this room needs to shift a little bit. Because it ain't just y'all listening and we talking and y'all talking and we listening. It's something else. Because ultimately we have to move beyond this point to a thought of what would legislation look like. So if there's enough people in the room who wants to make sure that CPMs their certification is recognized and they get to practice in the state of Georgia, and I don't know if they want to practice specifically in hospitals, they got to tell me. Or do they just want to be free to not be harassed to do it in home settings or birthing centers? But also there is a group of people, of women, okay, that are midwives. Some of them are still granted midwives. That means they have a whole long 30, 20 years of service doing this. And to be honest with you, they're not stopping regardless of what the bill says. Let's be for real, y'all. Who's going to stop? They're not going to stop, Now, even though we obviously don't want in Georgia the issue to be trying to put people in jail and felonies and all that, because we know we are tough on law, whatever Yeah, seatbelt safety. Yeah, but we tough on locking people up, all right? Now, but at the same time, there are a group of people who have done the skill, have a skill set, who deliver probably more babies than some CN certified nurses, and some have delivered more babies than some CPMs, and yet this bill, what comes forth, it don't have to be one bill, it could be several bills. We want to make sure that they still have the right to practice without going to jail. Let's be for real. And I understand from some of the other meetings that there are some states that have exemptions from the Medical Practice Act, which means that the law says it is best for them to be one thing, but if they're not that, and they are lay midwives or direct entry midwives, they still they don't go, it's not a felony, whatever, okay? It might even be a misdemeanor, but it's not a felony. We don't want to send women who want to deliver babies to jail in Georgia. Jail space needs to be for criminals. All right? All right. All right. So I just want us, as we look at that, the hypotheses that Nasra brought to us, who is a direct entry and lay midwife, she is, over how many years? 30. Okay, she's just young looking. But the bottom line is, what we want to do is to figure out how this thing rolls out, how it plays out, where there's still, people ain't going to jail, we have a quality situation, and then I also want to know, sometimes in the legislature, like when it comes to some bills, the two industries fight each other, and I want to know, are y'all going to try to fight each other? And what I mean by that is this. Some industries, like there'll be a fight sometime between the dental hygienists, and who they fighting, Stephanie?
I don't know who they fight.
It's like some people say they need more training, and other people say they don't need something. One group say they have more training, and the other group say they don't, and this group say, well, you should be able to do it. And then the ophthalmologists, they fight between optometrists and ophthalmologists. They fight because they say you shouldn't be able to put that drop in my eye, and the other say, yes, you should go to this degree, because I went to school for that drop to be put in that eye. So, it's not making it far so y'all can just understand the dynamics, but that's what it comes down to. One says my education level is higher, so I have a more professional expertise to do this, and then they say, well, I don't get as much training as you do, but this is simple enough that I can do it. And then they fight. And sometimes the optometrists win, sometimes the ophthalmologists win. All right? It's who lobbies the most, the best. So in other words, in this situation, what I'm saying is, I could want to know, how do certified nurse midwives feel about certified professional midwives, and how do you feel about direct entry lay midwives? And I want to get underneath the speaking, and I want to know, how do certified professional midwives feel about direct entry midwives? Because ultimately, I believe it's a way that we can come up with some bills that will satisfy everybody. All right? But now, if you want to, it could be a thing where there's an unspoken thing called, I think certified nurse midwives are the best. And all I want to do is make sure they get taken care of. Then it could be an underlying thing called, I want to make sure certified professional midwives are the best, get taken care of, because those people direct ought to get themselves together and go and take the class and do this. Okay? Yeah, because that's underneath some of the speaking in this room that's not being spoken. Okay? So what I'm saying is, I really want to know where people are about it. But I do believe we can come up with a compromise that allow all things to be honored. But at the same time, we can't fool ourselves if that's what's going on in some people's mind. So I don't want to put you on the spot, but you qualified, bona fide. You can sort of give us a feel. Do certified nurse midwives feel that certified professional midwives should all be nurses? And what do you think? Just open. There's no it's just, you don't have to be speaking for yourself. But what do you think about your profession? What do they think?
Do they have an official position?
Official position?
The official position of the American College of Nurse Midwives is that midwives should be educated through a program that's been accredited. It doesn't have to be accredited through the American College of Nurse Midwives.
Okay.
And they need national standards for testing and accreditation. That's our official position.
That's not bad. Let's give her a hand. I mean, it's not restrictive, so there's some openness in it. All right, thank you. All right, the accreditation that a certified certified professional midwife has, is it accredited by a national, which would it go along with what she just stated?
Our national certification is accredited through NOCA, which is the National Organization of Competency Assurance, the same as ACNM, or AMCB. ACC, which was a certification program through ACNM, has changed their name, so that's why we stumbled through the initials. We're still trying to get them in our mind. So our national certification is recognized and accredited. The educational routes are not all through accredited programs by the DOE.
Department of
Education.
Education.
NARM recognizes apprenticeship, self-study, CNM, ACC, or ACNM certification, internationally educated midwives. So it encompasses a whole bunch of different areas there. So the DOE accredited is one step, it's one route. They all have to pass the exam. They all have to have minimum standards as far as how many births they've done and all of that. But there is a grand midwife or experienced midwife route of entry. It doesn't require that they go to this school or have these midwives training them.
So based upon what she just said, does that kind of, how do you feel about what she just said?
Yeah, Claire, let's get into a debate.
I'm talking officially from the American College of Nurse Midwives. American College of Nurse Midwives would support legislation which would not support legislation which allows an apprentice model of education. That doesn't mean they would fight the legislation. We could stay neutral on it.
Neutral is good.
We hear what the women are saying about birth in this country.
One thing I'd like to say that's pretty interesting.
All right.
Claire is on the board of ACNM. I'm on the board of NARM. And I'm on the liaison committee between MANA, which is the Midwives Alliance of North America, and the ACNM. So every year we get together to see how we can play well together. And I think we're doing a really good job.
Okay, that's good. Well, did y'all hear what she said? It's powerful what she said. That's why I said let this stay up here. She says she's listening to women. I mean, at some point we must believe that what women have to say is worthy of being heard. You get what I'm saying? So we'll listen. If you listen to women, they're not caught up in all the dynamics of what we may be as legislators caught up in. They want a quality birth. They want to reduce risk factors, and they want to make sure they have a healthy baby, and a healthy outcome, and support, and family support around this particular issue. Okay, we got that. So there's some working together. Now, I guess I would have to. What I wanted to know is the claps in the audience came when I said that that people don't necessarily need to go to jail because they are midwives, and there was claps in the audience. So I already got the populace opinion, what the people say. Now I want to get an idea from you. What do you feel about that in terms of that specifically, and then related to what you think about direct entry midwives, and how do you believe that direct entry midwives can play a part in this whole situation? Because one thing for sure is, I talked to B.J. Walker, who's Commissioner of Human Resources, and someone from our office is going to be speaking. Dr. Brown will be speaking on the 28th. But when I talked to her about coming to speak, she said, infant mortality is my #1 issue. That's what she said to me at the biennial. She was at the biennial. I said, oh yeah? She said, it's my #1 issue is to reduce infant mortality in Georgia. That's what the Commissioner of the Department of Human Resources said. She said, public health is under my division. We'll send somebody. I said, well, Dr. Brown's already on the agenda. She said, fine. All right? So I just want to put that out there. That's what she said to me as of 2 days ago. All right? The other thing is, so I need to know how, in the context of it being a #1 issue for the Commissioner of Human Resources and in that department that deals with all of that public health and everything, and also the hypothesis that NASRA put on the table the other day was that to reintroduce midwifery into maternal care, that would be a direct relationship in terms of reducing infant mortality if there was more midwives involved throughout the state of Georgia in prenatal care and other things to reduce risk factors, all right? That was her hypothesis, and she asked for research to support it. Now, what I want to know from you is how do you feel about direct entry midwives, whether or not they should be penalized, whether or not you think they should. What do you think? And then I want to hear from Nasra, and then I'll sort of let people sort of flow.
No, I don't. I've never. We're all direct entry midwives, and we've practiced together forever. I think there needs to be accountability.
Okay.
And that, be it among the peers, my personal working with states all over the country, and hearing legislative issues and arrests, court cases, different things. I think it's in the mother and the state's best interest not to be focused on dealing with this criminally or through the courts when it can be done administratively. Even better than that is it's done among the midwives.
So do you know? So what you're saying to me that basically the lay midwives, the CPM, all basically know each other in the state of Georgia.
Oh yeah.
Yeah, y'all know each other, right? Lodge, you know these people?
Well,
they know each other.
We
just
know
saying.
each other if we show up at meetings.
Yeah. So
the rest are out assisting birth.
right, you're out assisting birth. Okay, so that's good. That's good what she said. That's good. Okay, Nasra, and then after Nasra, then I want my other committee members to speak, and then I'm gonna open the room up if y'all will allow me. And y'all just say what you want to say. You can talk about your births or whatever, but speak because this is what we need to know. Because otherwise, we just go on talking. Turn it on. Okay.
Greetings. My position with midwives is more us getting along and being able to not fighting and wrestling each other, and nor with the OBGYNs, but getting along because we do have a very serious disparity that we're looking at, and that is infant mortality. And our babies, they're babies that are still dying. I mean, you may have babies that are here and there, you have healthy births, but then there are a number of births that aren't going as healthy. And a lot of it is in our rural areas, and a lot of hospitals are not in places that can accommodate, nor are clinics to accommodate for prenatal care. So my position in being here as a midwife, and the focus in terms of how this bill or how things are being written up, is so that it's a friendly environment so that we can all be able to practice and address together as a team to address the infant mortality that's still high and what all those risk factors are, so that we can together minimize those risk factors, because you never know where it's going to be. You can't say, oh yeah, you're going to have the next one. It's not like that. So through what's already in place, being able to be a follow-up and insert so that we can seal it up, so that we can be able to have a little more substance to being able to reduce and minimize those risk factors.
All right. To Stephanie and my colleagues, what do you think about even what I said, what has been said, or whatever? Then I will open the list up because I don't want people to think they cannot speak. But I'm trying to get something. I'm trying to get beneath. I want to cut through the chase, because otherwise we get down to the end of this thing, and we just have talked and we listen, and you talked and we listen, and we really don't know what's going underneath as far as what people are thinking. And the bill comes out one way when it really could have been a more diverse situation in place.
Well, I'm going to be brief because the focus today is to give everyone who wants to speak an opportunity to speak. The one comment I want to make on the infant mortality, because that is a key component of what we're discussing here. We just came back, the legislators just came back from the biennial conference in Athens. The state sends us to school every 2 years. And it's a wonderful opportunity for us legislators, the new legislators, the returning legislators, to get education on state government. We have all sorts of breakout sessions throughout the 3-day period. And we had probably about 25 breakout sessions. And of those 25 sessions, there was only one devoted to children. I just think that says a lot right there. There's just one devoted to children. It was called Kids Count. And out of that, with that one session, I looked around the room, and there were, I'd say, I'm going to be generous, maybe 6 legislators out of 256 who attended that breakout session. The others went to the transportation, or I can't remember what the other one was, maybe health care. But that really upset me, because every campaign season, you look at any material put out by a candidate, and they've got children everywhere, and they talk about children, and that's top of my platform, and I'm going to get to the Capitol, and it's all for the children. But then they're not there for the seminar, and when we go through the budget process, the first thing to be cut is DHR, children's welfare funding, and funding for caseworkers, and so that's going to be my big issue this session. Has always been my issue. But infant mortality is a key issue. And at that seminar, and I know Nazar was there because she sat right by me, that seminar, they said if you reduce, if you can just prevent 1 infant death per county in Georgia, 1 infant death per county in Georgia, what do we have, 159 counties. You can prevent 1 infant death per county in Georgia, we can lower the infant mortality rate in our state by 10%. That, to me, is a doable goal. And I think what we're doing here with trying to focus on the whole care and the midwives being involved throughout the process with nutrition and teaching women how to be healthy with their pregnancy to prevent the low birth weight and to encourage a healthy pregnancies, we can do that just through this committee. We can decrease the infant mortality by 10%. So that's my comment for today, and then I want to hear from everyone else. Thank you.
Spoke about partnerships in wraparound services.
Well, thank you. Like I said, I'm Donna Sheldon, and it's been interesting the past couple of study committees. I've enjoyed it, and I guess basically where I'm coming from right now is I know most births are 90% are safe, but just from personal experience, most of my family seem to fall in the 10% category. And so that's the 10% I'm very concerned about, because when a birth is great, it's great. But when things go bad, they go bad quickly. And so I just am, that's just to let you know, that's definitely where my concern is. I actually considered home birth myself, my first child, but thankfully we did not go that route based on my delivery. But anyway, that's definitely a concern. I know I also was at the biennial this week, and although there was only one conference that's specifically directed at children, most of our focus was on health care issues in Georgia, and which definitely impacts children. And there's a real need and an awareness to improve infant mortality and health care for children in Georgia. I serve on the appropriations for health, and that is our focus. Is not always, especially we had a great vice chair the past couple of years, and he is no longer with us, but he has always directed us that as we look at the budget, we must make sure that we are not saving money, but we're improving quality of care for Georgia citizens, and that's our focus. But another committee I am chairing, a subcommittee on looking at public health funding formula in Georgia. And one of the things, Stephanie, you may want to have, since we're talking a lot of focus on infant mortality, this may be off the base, but there is a great program in Dublin, and it's called Healthy Start. And they have actually decreased their infant mortality rate in that area. There's about an 10 county, general population they're serving, by 37%. So there are programs out there we are addressing, and I do appreciate all of you ladies that are midwives, and you definitely, I know you listen to women. I've encouraged that, but just to let you know, that's where my concerns are. In any legislation as we go forward, I think we have to look at those emergency situations, what happens when you do have to go to the hospital, who's held liable, what is the liability to the hospital, what's the liability to the physician that has to take over once they arrive. But we have to address that issue. We can't just continue, we can't just act like all births in Georgia just go smoothly. So, but thank you.
Thank you. I would like to, I'm glad to know that Representative Sheldon is on those committees, because you actually do have to have people sometimes strategically in place. And I myself was very glad to see a lot of emphasis on health at the biennial. A lot of emphasis on health. It really was. And I went to a lot of the health ones, especially on this managed care piece that's been put in place. That y'all, the public, will find out about soon. All right. And then Nasra was with me, so she went to the one on education. But but I'm on health and human services. But a lot of decisions are made at the budget level. So we do know. Glad we know we have someone who kind of has listened to all that's been said. Because then when the decisions are made, all that will be in the backdrop of how decisions are being made. So we do appreciate that. I used to run a program called Starting Points in Vine City, and basically it was through the Carnegie Foundation in City of Atlanta. And what we were charged to do is to improve health outcomes from young people from the ages of 0 to 3 years old. And so Healthy Start is one of those type programs that really, if you really put the correct funding in place and really make it whatever, 35% decrease is 35% plus decrease is excellent. I mean, that's like a model. So there is some things that we can do working, and like that. That's that whole wraparound partnership program that Healthy Start does, and I'm familiar with it, but I didn't know the results were so strong. So thank you. The issue of liability has come up more than once, and so the issue would be, question I think is how much is liability insurance? Who mandates it? And I heard you talk about I think you said the availability of it as well as the cost of it. So I want to know, what is the cost of it? Is it who mandates that you have it, and what about the cost of it? Who do you get it from? Ms. Clark.
That might need to be turned on.
Yeah.
Somebody needs to turn this on.
Employed midwives are often covered under the physician's policy if they're employed. I'm covered at Emory University through the self-insurance through the Alameda for the Fulton DeKalb Hospital Authority. So I don't pay for malpractice insurance. I think for liability insurance. It's mandated to have credentials in a hospital. You can't go bare. If you're going to go play in the play yard of the official place, you have to have the right protection, and they don't want to be the deep pocket. So you're mandated when you go for credentialing. You can't go bare in Georgia and get hospital credentials. I've heard the rate for insurance depends on your history and how long you've practiced. I've heard for nurse midwives, it's not uncommon that either the midwife has to pay or the physician practice has to pay $35,000 a year, maybe even more. There is also the issue of the tail. So I personally know nurse midwives who cannot retire because when they retire, they are still at risk, liable for all the births they ever did in their whole career. So they have to buy the tail of the insurance that covers them until they die. And there are nurse midwives who are being asked to pay tails of $40,000 or $50,000, and they can't afford to retire. So they can't afford to quit. Well, so no, I don't. The home birth insurance through through ACNM, I don't know what they're charging midwives who do is. They can they're getting it, but it's the squeeze is on. The big squeeze is on. Big squeeze. It's available now, but and ACNM has committed to making it available, but I don't know whether there's only one carrier that'll cover home birth. There's only one. I'm going to say it's AGI, and I don't know what that stands for, so I'll get you the information.
Okay.
Can I ask, does do nurse midwife groups pool, the American College of Nurse Midwives, do they offer, like I know I'm a member of the American Bar Association, you can, as a sole practitioner attorney, you could purchase through them at a reduced rate because they collectively bargain for you?
Yes, but the pool is pretty small. It's less than, I think the pool of our midwives who buy insurance through that is less than 1,500 nurse midwives. Because most nurse midwives get their insurance other places, through other mechanisms.
There's no law here that says you have to have malpractice insurance. That's just if you want privileges.
Can I ask Debbie Pulley how some of the CMs how y'all, I'm sorry, CPMs, trying to get all my acronyms correct, how the certified professional midwives acquire insurance.
In most cases, they don't carry malpractice insurance. If the legislation that's gone through hasn't required it. In each piece of legislation that's gone through in the last decade, there's been an exemption of liability for the physicians or who's advised any health provider who accepts consultation or referral from a midwife, directed to midwife, is not liable for any act commissions on the midwife's part. They're only liable for gross misconduct, one act, gross negligence on their part after they've received the transfer of care. And there are, I'm sorry, there are two states that do require malpractice insurance. We take the bus. That's Florida and Westall.
Anybody understand that? Okay. Y'all got kind of stiff on me, man. Everybody stand up and stretch. If you don't stand up and stretch, it's all right. So y'all get
I do want to make a brief comment in response to some of the statements made by Representative Sheldon, which were very helpful. And I know we all share concerns about that 10% or whatever of the high-risk births or the births where things go wrong. And I do want to let everyone know we have invited and they will be speaking the American College of Obstetricians, the Georgia chapter. We'll have speakers or a speaker from their organization. We also have the Hospital Association that will be speaking. We have Medicaid. We'll be talking about some Medicaid coverage issues. So we do have some speakers to address some of these issues. I think it's very important. And public health, the Georgia's Director of Public Health, Dr. Stuart Brown, will be speaking. So we do have some speakers coming up to address some of these issues of real concern. Miller, can you provide us with a copy of your informed consent document? If you could get that to our research person, Sally Fox, she can. I would really like to see that. Thank you. I'm going to add, anyone who speaks, you're welcome to present written copies of your testimony to Ms. Fox, and that will be distributed to the committee members. There are some members who could not make it, so if you want to make sure that all the members get the benefit of your testimony, we invite you to present written copies of what you say to us today. Thanks.
Hello, I'm Melinda Delisle Clark. I've been a childbirth educator in Metro Atlanta since 2000. And before I get to what I had actually intended to say today, I just want to speak for a moment to the issue of infant mortality and actually prematurity, because I believe they're very closely tied together. As a childbirth educator, I have gotten to see the gamut, and I've even had, student couples who have had babies who haven't made it. So I understand where that concern is coming from. But I want us to take a look at, first of all, the research, which unfortunately I can't delve into much today, but I will submit it written to Sally here within the next couple weeks, is that we know scientifically that lifestyle issues do impact the risk of infant mortality and prematurity. We know that good nutrition, adequate vitamin C, adequate protein, good hormonal balance. There was a study released about a year and a half, 2 years ago, that 40% or more of premature births are due to an imbalance in estrogen and progesterone. That can be remedied nutritionally, through supplements. A lot of these issues that lead to those problems can be solved. Now, you can't entirely eliminate risk. I'm not so naive as to say that. There's no way of completely eliminating that risk, just like you can't when you drive. But we can bring those risks down. And through my students' experience with their practitioners, I know that midwives, whether they be certified nurse midwives, certified professional midwives, or lay midwives, spend more time and focus on those kinds of issues than the doctors are able to. It's not that the doctors don't want to, they just don't have the time because of their other expertise. They have to go off to surgery and doing other things that the midwives don't do. So they can't spend the time on the lowering the risk. So that's one brief issue there. Also, I just wanted to help answer that question of, is there a need and a demand for home birth midwifery in Georgia? I've talked with a number of pregnant women over the years. Of course, not nearly so many as a doctor or one of the midwives has. But women call me not just for my classes, but just for information. A lot of times I'll get calls from someone where they've just found out they're pregnant, and they're calling up and saying, who's a good birth attendant for me to call? And I respond, well, what kind of birth do you want? Well, I was thinking maybe about a home birth, maybe about a hospital birth with a midwife. Who can I talk to? And when I explain the current illegal status of home birth in Georgia, there's very often disappointment. Oh, I can't do that here? Oh. Then, some of them, of course, eventually get into my classes sometimes, but they still have that desire. And so they pick one of a few options. Some of them will go ahead and have a home birth anyway, as we all know happens in Georgia. Some of them will go ahead and settle for hospital birth, and then they usually come back and say they're going to do a home birth for their second. Some of them will go ahead and say, well, I'll have that hospital birth, but I'm going to arrive at the last minute. And as any professional in this room knows, child professional knows, that's actually probably the least safe option of all of them. Because any midwife who's experienced is going to be able to be there and detect problems when they first start. And then they can be dealt with if they happen. Arriving at the hospital just in time for pushing kind of opens the door. Now, granted, fortunately my students haven't had a problem with that, but it does open that door wider than having a midwife come to their home, stay there with them, check up here and there in a very non-invasive way, and just make sure that everything is flowing smoothly. I've actually also had a few students go out of state to get the kind of birth they want. I've had students go to the farm, to Chattanooga Birth Center, and to a birth center in South Carolina because they want a more personal, intimate experience with someone who's going to stay with them and not change shifts every 8 hours or 12 hours, depending on which hospital you're in. And they're willing to travel, upset their whole life for weeks so that they can get that experience. So what people want is they want what's best for their baby. They want it to be safe, but they also, not just safety, but they're balancing that safety with the kind of environment and experience that they really want to bring their baby into this world with. They also want it personal. It's very hard to labor in a sterile environment, as I'm sure you've heard from everybody else. And having been to a number of births as a doula, you also see that in the hospital, where it's harder for people to settle in. Something all childbirth, a doula is a professional who goes and attends birth with the mom. We don't catch babies, but basically the duty of the doula is to help mothers remain more comfortable, relaxed, and support the emotional and physical needs of mom and her partner.
I just say that so people can understand when you speak and you don't assume that everybody know every term, because that way you make sure people understand what you just mentioned.
Appreciate that. So in the hospitals, it's something every childbirth educator is taught to teach couples. When you go to the hospital, plan on your labor slowing down. It will. Because unless you're just about ready to push, then it might not happen. You know that contractions will space apart. Sometimes even the cervix will close up a bit because of the added stress and strange environment. Sometimes this problem adds to that need for Pitocin and other augmentation techniques to help speed labor along, and that, of course, the studies show also will lead to surgery, increased rates of surgery. So what's the big picture? What we're trying to do here is make sure that families and babies get what's best for them. And really it comes back to choice. Let people know the information, decide how they feel, and have the options to be able to make the choice that's best for them. For some people that's in a hospital with a doctor, some people it's in a hospital with a midwife, some people that's a birth center, some people that's at home. But we need to let people have the option to be able to make the choice that's right for them, and give them the support to make sure that works as well as it possibly can. Actually, I'm currently taking a break from teaching, but I had taught in Marietta and in Buckhead. And,
did they practice? Or?
No, I taught independently. So I was not, though I have a number of friends who are hospital childbirth educators.
18 months ago?
I was still teaching.
I don't have
Okay, and then we have Crystal, Ruth Cox, and Amy Williams in that order.
Hello, my name is Crystal Merrell. I am the mother to two daughters, Jordan, age 6, and Eva Rose, age 6 months. Jordan, my first child was a hospital birth, and Rose, of course, was a home birth, and with a direct entry midwife. My home birth, it started just the way I wanted it to, after a good night's sleep. And I woke up in labor, and it was June 26th, so it was well into the hot part of summer, but this day wasn't like that. It was cool and quiet and misty. It was that kind of day. My older daughter and I went outside to pick blueberries out of the yard. I sat on the front porch in the rocking chair and thought about how I wanted my birth to be. Yeah.
I was trying to get her authentic voice so they'll know that we really have babies here too.
I think we're going to get her authentic voice pretty quickly.
Yeah, she's ready for a nap. But my midwives arrived and checked the baby and me, and I got into my birthing pool. Yeah, that was in my living room. And the way I labor is kind of intense. It's chop, chop, no break. You know, it's not a contraction with a space in the middle. But so the birthing pool gave me the opportunity to finally relax. And my body responded with the huge urge to push. And I said so, and my midwife told me, she said, just do what your body tells you to do. And, sorry, that one means so much to me that she said that. And I did for an hour, and during that hour, I was so there. I was so connected. I was so, felt so powerful. I could look around my home, my treasures, things I cherish, the picture of my grandmother who passed away a couple of years ago, pictures of my daughter when she was a baby, and I felt so connected is the word. I was present, and I really appreciated that. My hospital birth 6 years ago was with a certified nurse midwife, and I chose a certified nurse midwife after being at a practice with doctors and maybe one midwife left in tears practically, and thought this was my only other option. And the hospital, it was a good experience. I delivered without drugs or vacuums or forceps, any of those things, but it was atypical in the fact that I labored for 14 hours at home out of an 18-hour labor. The last 4 hours to get dressed, drive, admit, settle in, and like the last speaker just said, my labor did slow down. I can totally relate to what she said. So I was surrounded by unfamiliar walls, unfamiliar people, in an unfamiliar bed on a floor that I didn't trust to put my bare feet on. So I was very disconnected and closed my eyes and went inside of myself to do the labor. And I really wasn't aware of much of what was going on around me. It's like night and day, really, the two experiences. I felt so, at the hospital, I was in their domain. I was the intruder. At my home, I was powerful. I was in control with the support of my midwife and apprentice who were there. And I want direct entry midwifery to be legal in the state of Georgia for me, just in case I get to have another, but for my daughters, my two daughters, when their time comes, I'd love for my grandchildren to be born at home. Thank you. Thank you so much.
She's
You got her?
here.
You'll turn her back when she starts screaming.
Cox, Amy Williams, Marion Hinton.
Tiffany Clam.
Thank you.
All right, Tiffany. Okay, we'll rotate her right after Miriam.
Thank you for the opportunity to speak this morning. I'm happy to be here. I want to speak this morning as a consumer, but you should also know that I am an apprentice to become a midwife as well. I urge you to strongly recommend licensure for direct entry midwives to our legislature this coming January. It is high time that Georgia joined the ranks of states committed to high-quality child and woman care during pregnancy, birth, and the postpartum period by ensuring the availability of direct entry midwives in this state. My family, my parents, and their children have chosen home birth repeatedly over the last 27 years. It was a gradual move from my parents, who struggled to find hospitals and doctors committed to safeguarding normalcy in childbirth. My birth, my personal me 27 years ago, at home by a well-trained and equipped home birth provider, set the standard of care that my family has come to expect. My extended family has experienced 4 home birth non-emergency transports in labor, 3 for cesarean section, and 1 for an epidural and Pitocin drip. They were appropriate, timely transports and led to good outcomes for mother and baby. I want to emphasize that as a college-educated family with quite a few graduate degrees as well, we trust direct entry midwifery educational standards. Midwives have statistically proven themselves repeatedly to have as good or better outcomes for low-risk pregnancies than high-technology use hospital practice. and I've cited the CPM 2000 prospective study for home birth. Direct entry midwives have lower use of interventions, use less dangerous interventions, and are equipped to safeguard normal childbirth, which 90% of pregnancies and births are. Representative Sheldon, I'm really glad that you brought up the 10% of births that aren't, because my child, who is a year and a half playing at the back of the room, fell into that category. I developed preeclampsia, and my direct entry midwives were able to monitor me at home, guide me to manage it in a stable way until I reached term, at which point I went into labor and was transported for a planned C-section. My child, Anjali, was born with a normal birth weight and in good condition. And so I want to say that even for the 10% that have complications, it is safe to work with a direct entry midwife. They are trained to recognize complications, to deal with them appropriately, to transport as needed, and to stabilize mother and child. So in closing, I want to urge you, the representatives, the Georgia Senate, our doctors in Georgia, ACOG, the Public Health Association, the ACNM, and families in Georgia to support what is best for mothers and their babies. Please license direct entry midwives. Thank you.
Okay. Yes, Amy and Miriam, and then we'll go to Tiffany. Yeah.
Hi. My name's Amy Williams. I live in Powder Springs. My husband Kyle and I have 4 children. My first was a hospital birth. My last 2 were home births, planned. And my second one was a planned home birth where I was transported to the hospital. So the 2 issues that I kind of wanted to focus on kind of were brought up today. So as many people here have attested, home birth is a safe choice for low-risk women. Having my babies in the comfort of my own home was wonderful and empowering. I said I want to focus on 2 aspects. First, the unbelievably thorough and professional prenatal care I received during my last 3 pregnancies. My home birth midwife, along with her apprentices, spent a full hour with me at each visit. Not only were the standard monthly assessments done, but she would also discuss things with me that I feel are extremely important to a mother and baby's health. My nutrition, which is what we've talked about, that I think is huge for input to help with go to full term, to carry the baby to full term. Nutrition, vitamin intake, my stress level. She talked to me about my exercise routine, things just were going on in my life, my family's life, my interests and hobbies. The care given by her, or I think a home birth midwife, is so much more than doctors and midwives who work out of a hospital just have the time to give. I don't think it's that they don't want to. I think there's just not the time. The second thing I want to testify to is the midwife's realization of their limits. And I'm going to talk about my transport real quick. My labor with my second son was going along fine. The heart rate was fine, and I was progressing. But when my labor slowed down, and after my midwife had me try things to speed it up, and by that I just mean walking and nipple stimulation and getting in the bath and getting out of the bath, then she tried and encouraged me to rest. It was late that night when my baby became stressed. There were decelerations in the heart rate that were lasting beyond the end of the contraction. We immediately transported to the hospital. I was examined. I was there a while. I received fluids, an epidural, was allowed to push for a while. After 6 hours at the hospital, I had a C-section, and my perfect son, Sam, was born. Looking back, after it was over, my husband and I were so impressed. We were upset that we couldn't have the baby at home, but we were more than that, so impressed with my midwife. The transport was handled beautifully. She remained calm and kind, but she made it very clear that it was urgent that we get there. It was only a matter of minutes before I was in the car and we were all headed to the hospital. And I just want to add, I don't have numbers like so many of you guys do, but I wish she was still in here, Representative Sheldon, but I know she said when problems happen, they happen quickly. And again, I don't know, but I know for sure, but my understanding is that most problems, almost all problems, are detected early on with very close monitoring. It's very, very rarely something that's like very quick, oh no, a problem. So midwives go through extensive training, and they know that birth is normal and natural for a woman. They monitor us laboring women so intensely and closely to the point of knowing if we need to be alone, if we need a drink of water, a bite to eat, or just a hug and positive words. And when it sometimes becomes necessary to seek medical intervention, they are not too proud to do so. And they're grateful the hospital is there for us when we need it. And I don't even know if I'm saying the right thing here when I say, or who I'm asking what our exact goal is of the study committee, but we Georgians must have legal access to a certified home birth midwife and to the legal option of birthing our babies at home, and whoever is in control of this decision, please grant us that. Thank you.
Thank you. Very good. Miriam, Tiffany, and then Linda Dotson.
I'm Miriam Hinton. This is Naomi. I'm an abysmal public speaker, so I'm just going to read my statement. When I first became pregnant, I assumed that I would have a choice about where I had my baby. I could go to a birth center, have my baby at home with a midwife, or go to a hospital. Little did I know, but according to the state of Georgia, I had no choice. I had to go to a hospital. At first, I was shocked. How could a major metro area like Atlanta not have a single birth center? For lack of any other choice I could see, I continued seeing my regular OBGYN for my prenatal care. As soon as I began researching pregnancy and birth, I knew that I wanted a drug-free, intervention-free birth for my baby and myself. I explained this to each doctor and midwife that I met with at the OBGYN practice. At around my 5th month, I met with the same CNM I had seen the month before. Her answer to my first question began with, "Well, once you have your epidural." I was flabbergasted. Not only had I personally told her not 1 month before how important a natural birth was to me, but it was right there on the chart in her hand, the very next item next to my name. If my care provider could forget or overlook such an important detail, what else would they forget or overlook? Would somebody overlook my allergies? Would they forget the fact that I was Rh negative? My husband and I were desperate to find another option for my prenatal care and birth. After extensive searching, I was able to get the name and phone number of one of the most qualified and experienced midwives in the state. The care I received from this midwife and her partner was phenomenal. I trust them more than any doctor I've ever seen, and they never forgot a single detail about me. They even remembered my mother's and my grandmother's birth history. The point of my anecdote is this. My direct entry home birth midwives treated my family as individuals, not some number to be put through the baby factory. What is right for some people is not right for everybody. Consumers who want to be responsible for their own health need to have the choice. I want that choice for my next baby, and I want that choice for my daughter.
Okay, Tiffany, Linda Dotson, and Christina O'Shea. Now, let me say this. The reason why I'm calling them 3 at a time is I want you to come on up because the time is getting away from us, and some of the members have to leave. So if you kind of be ready, you know you're next. You got to come on. So because that even that transfer time is getting us, because we try to get you out in 2 hours, no more than 2 hours and a half.
Do you want me to speak on Monday? I can speak on Monday.
No. The day is your day.
No, there is no time on Monday.
My name is Tiffany, and I'd like to briefly tell you about my journey to home birth. When I was pregnant with Ethan, our first son, I lived out of state, and after going to an OBGYN for several months who told me I needed a cesarean because I was too small to give birth, just like my mom was too small and had cesareans, my husband and I did a lot of research and soul searching and decided to have a home birth with a certified professional midwife. At 8 months of pregnancy, my husband got a job in Georgia. We moved to Georgia, and I thought, well, I'll just find a midwife in Georgia. This was not the case. It was very difficult. It was very disconcerting to try and find a midwife who wasn't completely silenced and underground because, it's not supposed to be done. Needless to say, we found a wonderful midwife, and we hired her. 2 weeks after my due date, I went into labor with Ethan. I labored for 44 hours. I wanted to labor for 44 hours, and I wanted the choice to be able to labor for 44 hours. I was given the choice, do you want to go get an epidural, get some sleep? It's been a long time. And I said, well, is the baby okay? And my midwife said, of course he is. She had been listening to the baby and charting him and charting me, and we were fine. So I said, well, let's keep on. And she supported me and encouraged me through all of those hours of laboring and giving birth to Ethan. He was 10 pounds. 10. I'm too small. I wasn't too small. And my midwife knew that I was going to be able to give birth to my baby. So I had Ethan at home. He is 9 years old now. Since Ethan, I've had 3 other children, all boys, a 9.5-pounder, a 10.5-pounder, and my little 8-pound baby boy. I think that women need to be given the choice in Georgia, if they want to labor that long, to let them. If they want to give birth at home in the kitchen in a big old birthing pool, that they should be able to do that with a trained professional by their side. And in the other state I lived in, Medicaid and insurance would have paid for my home birth. And in Georgia, you have to pay out of pocket. And there are women who want to have home births who cannot financially afford it, and they need to be given the choice to have a midwife and to have compensation from their insurance companies, because the midwife is legal in the state of Georgia. Thank you.
Let me ask you very good. 2 questions.
Yes, ma'am.
What other state were you?
South Carolina.
Okay.
2 hours away.
Okay.
2 hours away.
What's the approximate fee that you were charged for?
In South Carolina?
Yeah, well, matter of fact, South Carolina and Georgia.
In Georgia, $2,600.
Okay.
I think. And in South Carolina, I think it was the exact same. It's just that in South Carolina, I was on Medicaid, and Medicaid paid half, or around half, and so it was just difficult to try and think, oh no, I have to come up with a whole fee myself. We were both students in college, so. Yes,
Thank you.
Yes, ma'am. The midwife was licensed through the state, and so she would turn in the paperwork to the state, and they reimbursed her, and then I was responsible for the part that they did not reimburse.
Did she still see you thinking about paying the remainder?
Yes. Yes.
Thank you very much.
Thank you.
All
A
right.
few goats would cover it.
A few goats. So.
Chickens.
These are my kids and my husband.
Here, I'll hold it.
Yeah. I'm the mother of 6 children. My oldest 5 were born at hospitals here in Georgia.
Linda Dodson.
Yeah, Linda Dodson, sorry. Yes, I am.
Okay.
Were born at hospitals, and my last child here was born at my home. For today, I'll let someone else handle the safety research. I've done it, otherwise I wouldn't have done this. But I want to focus on the aspects of a home birth that I can't get at a hospital or clinic. Familiar caregivers and familiar surroundings. Home birth allowed me to easily meet and know who was going to care for me during labor. My midwife was at all my prenatal appointments, save a couple of appointments. Both of her apprentices were there also. I knew all 3 of them and was comfortable with them before delivery. An hour was set aside for each appointment. And they're talking about the health things and the nutrition. Somebody else said that's what we talked about, and anything else I want to talk about. I had spent a lot of time with these women before they delivered our child. When someone cares for me in such a personal way, I know it was very helpful to me emotionally, which follows that it helped me physically to have an easier delivery. He happened to be sunny side up, by the way. My midwife was with me from the start of labor till the baby was in my arms. When I delivered in a hospital, all 5 of them, I met the nurses upon arrival with me already in active labor. I don't know to what length you'd have to go to meet and be comfortable with all the nurses who might possibly attend to you during labor at the hospital. The nurses are really the ones who care for you for the majority of your time at the hospital, in my labor experience. I never saw much of the doctor-enteral transition, and my 5th delivery, I told the nurse I thought our baby was about to make an entrance. She brushed it off and told me she checked, and I was just only 2 centimeters. My husband sent his mom after her seconds later, as he recognized, after having me do this 4 times before, how I acted right before that head appears. And the nurse ran back, and our 5th child joined us as she came in the door. OBGYNs usually come in groups. Even when I've made the rounds and met all of them over the course of my prenatal appointments, about that time they've walked in for the last little bit of labor, they've probably spent maybe 10 minutes with me. And at the appointments, I've often felt like I've almost needed to grab onto one of their coattails so I could ask a couple of questions as they flew in and out of the examining room on their way to the next person. I stayed with the practice for my first child only because I was okay with 4 of the 5 physicians and I didn't know what else to do. I'd already gone through 3 practices. What were the odds that the one I really disliked would be on call when I went to deliver? Yep, he was the one on call. My second child, I purposely picked a practice with 2 doctors. A third was added about a week before I delivered. I met him for the first time when he informed me that I was 8 centimeters. Even choosing a practice with CNMs to deliver one of my children, there were at least 8 from other facilities that could have ended up delivering my child should they have been on call. These situations produced people who knew very little about me except for a few things on a couple of charts. Birth to me is a whole person and a whole family experience, not just physical. I feel that when someone does not know me at all, they cannot care for me the way I need to be cared for, or to be very encouraging and helpful to me at time when I need them. The midwives had spent many hours with me and any of my family members that came to the appointments before they ever delivered my baby. It was very comforting and peaceful to me. They knew and cared about what my wishes were for the birth and allowed anything that they felt was not putting me or my child at risk. I felt like they knew how thrilled we were to be able to welcome another little one to our home, and they knew that this baby was wanted and long awaited and not just some surprise. Childbirth is a very emotional and spiritual experience to me. Childbirth is a very personal experience to me. At one point, one of my doctors told me that when I asked what to do for lower back pain, that we evolved from apes and really should be on all fours, and back pain just comes with the territory. I have no problem with people having differing beliefs from mine, but having someone care for me in this personal way who is so not on the same page as I am, I've done it both ways, and I prefer someone with a light mind who believes, as I do, that children are gifts from God and precious. The second thing home birth gave for me is a familiar, comfortable surrounding. Not being rushed in any way from room to room. Not having my husband fill out more paperwork, even though I did pre-registration. Not having my baby apart from me at any time. Having whoever I wanted around. Having the midwives very careful to be more in the background or as in the middle of it as I wanted. Nothing can top home for familiar. On more than one occasion at the hospital, it was insisted that I move to a different room when I didn't feel up to it, and especially when they wanted to clear the labor and delivery room for the next person. It wasn't like I took very long in those rooms. I usually delivered within an hour of arriving. Actually, usually it was a half hour. Our third child, they took from us, and he was gone for hours with, as far as I was concerned, not enough communication. Home was a wonderful place to welcome this last child. I only went to the doctors in the past because I felt I was irresponsible if I did something else. You cannot imagine how thrilled I was to learn about home births, research it, and do it. We have been so glad to have had this experience and choice. We want this to be a clear choice for our children and for whoever wants it. As a side note, doctor care and the hospital for this child would have only been $10 copayment total. We paid for it out of our pocket, $2,500. My husband and I both have bachelor's degree. I used to teach school before we were married. We are not anti-medical. We are so glad hospitals and doctors are there for our medical needs. We hope we will need a midwife again in the near future, but if not, we are also putting our voice in so our children and others can have this choice. Thank you for your time. Very pleased.
If the persons who have already spoken, we need your email address, because some didn't have the email address. You got all of these? Okay, good. All right, good. We want to make sure we be back in communication. Okay.
Thank you. My name is Christina Plochet, and I am the mother of 6. My first 3 were born in the hospital, and my last 3 have been born at home. My initial reason for choosing home birth was not really any romantic notion of getting back to nature. It was pretty practical. My third child was born 10 minutes after we got to the hospital. I was only in labor for an hour and 10 minutes, and I decided I'd rather be prepared for a home birth than unprepared for a car birth. Which I was very, very afraid would happen. My children are born early. We're lucky to get them only 2 weeks early, and so we didn't feel that being induced was a responsible choice. So we looked around, and we found a midwife who is actually just 3 miles from my house. My husband and I met with our regular practitioner. We met with the midwives, and we felt like that is the way that we wanted to go. The things that I wasn't expecting, the benefits, were things that other people have mentioned. One, the quality of care. I think I spent more time with my midwives in the first visit than I saw a single practitioner in the entire length of my pregnancy. And that is so comforting to me. I need that when I deliver a child into the world. And I feel keenly my responsibility to bring up the children that I've brought into the world, to bring them into the world in a good way, in a healthy way, and to bring them up to be good citizens and contributing members of society. And this home birth choice is a responsible choice. It's a responsible option. It also is physically easier because I didn't have to go through the trauma of being in labor that far along in the car, getting out, moving everywhere, 24, 48 hours later, coming home, unpacking. I was so much more rested. It was very physically easier. It was also peaceful. There wasn't the drama, anxiety of the hospital, which I didn't really notice before until after I'd had my baby at home. And people would say, how was your labor? And at the hospital, it's like, this happened, this happened, this happened. At home, it was like, well, I went in labor and he was born, you know. And it was just so nice. So I just want to say I'm so excited. I'm just so happy that you guys are looking at this. I'm just thrilled to death, and thank you very much. And I just hope that everything will work out so that home birth is a responsible option and that it will help to make it a more viable option for us all. Thank you.
Thank you.
Yes. No, they were not, but they were still early. They were early. Mm-hmm.
The next three speakers are Valerie Regis, and Ryan Roney. And then we have Lynn Clark, so I just get four.
Hi, I'm Valerie Vanderlip. I live in Marietta, Georgia. I'm a lactation consultant, and I have 3 children that were born in hospitals. But I have many dear friends who have had midwife-assisted home births, and I've been able to be with them for their births. I want to say the F word, and that word is fear. Fear is what keeps women from having the kind of births that they want to have, and what conquers... See, I got your attention. I got you. But now you're paying attention.
Yeah,
okay. Well, what conquers fear is love and knowledge, and midwives provide love. And it's through what everyone else has said. It's about spending more time with that person. Doctors, I'm sure, want to be loving, and I'm sure that in the hospital setting, they want to convey that warmth. But when you don't have time, it doesn't come across. You have to do just the facts, ma'am. So when a woman has more time to be with that midwife in those long visits, in those many hours over the course of the pregnancy, there's a love that develops, and that helps to conquer the fear. And there's also that knowledge that is shared, which helps to conquer the fear, so the women have better outcomes. I also work at a crisis pregnancy center in Marietta, and have for the past 3 years, and I've met many women who come in for a pregnancy test at 5 months or 6 months in their pregnancy, have had no prenatal care, many times are not citizens. They have been either concerned that they could not receive Medicaid because of not being citizens and not aware of the Green Plan, or uncertain about what they were going to do in their pregnancy, just having no one to turn to. Those women put themselves at risk. Their babies are at risk. I believe that the more options that we have, the more possibilities that women have of finding someone to care for them, the better the outcomes will be. And it's especially going to impact those women that are on the fringe of our society. Thank you.
Thank you.
Hi. My name is Valerie Regis. I'm a college student working towards a master's degree in nurse midwifery. I'll be starting that program next summer, and that's the main reason I'm here. I just wanted to speak to 2 issues. One, the view that certain types of education might be better than others. I think sometimes we forget that obstetricians are specialists. They're designed to treat problem pregnancies. That's what they're trained in. And when I open up obstetrical textbooks and I see 40 pages dedicated to normal, healthy labor and 800 pages dedicated to what could go wrong, that reminds me that, we ought to be going to general practitioners for general pregnancies, and that's what a midwife is. Much like, you wouldn't go get your annual physical with the neurologist, you go to your general practitioner. It's pretty much the same thing, but thank God they're there. When my mother was 5.5 months pregnant with me, her uterus ruptured. And thank God there was an obstetrician who could help her and keep her together long enough to carry me to 7.5 months. And I am so grateful that that exists. At the same time, because of the sternness and the nature of that level of responsibility placed upon obstetricians, my mother can't tell you what I looked like for a significant number of hours after I was born. She has no idea. She can't tell me anything for the first day. When midwifery is legalized and they can work, sorry, I'm terrified of public speaking. When midwifery is legalized and they can work with the specialists and not have to be afraid of each other, then it's possible to have, if there's an emergency, a physician who's capable to perform these miraculous surgeries and this craft while still having the personal attention that a midwife affords. And I don't know, I wish that my mother had had that option so that she could tell you what I looked like. So, that's all. Thank you.
Thank you. Thank you.
I wish there were more men here. This is not just an issue that's just for the women. Birth happens because of our relationships. And we have to...
Are you Ryan Rooney?
Yes, I am.
All right, gotcha.
Yes. Valerie's my wife.
Okay.
We're not going to have children yet, but when we do, I want my children to have the best care possible. My wife has allowed me to be the leader of our family, and I think every man needs to look for the best options for his family. And I'm lucky that I have had the example of my mother, who has had home birth and midwife birth in the hospitals, but has had good experiences, non-medicated experiences for her 5 children. And that has instilled in me that I want that for my children. However many they will be, I want my wife to have the choices and the options available in this state. I don't want to have to go to another state. I don't want to have to seek someone who will do something and risk their legal standing in the state. I want that for my family and for my children, and I want that for everyone to have. And I want that to be options. That's what it is. It's not telling everyone that they have to do that, but that option needs to be allowed and be available. And I feel that is the best option for my family, and I want to be able to make that choice. And I think I'm grateful that it is finally coming to an open discussion in this state. 25 years ago when my brother was born at home, my mother had just moved from Idaho, where she had planned to have a legal birth with a midwife. She had to find a midwife and find a doctor who, on the sly, would still take care of her with no intention of ever going to a hospital. I remember being at home when that happened, and then I remember being blessed to be at the birth of my brother 20 years ago when I was 7, and that has stuck with me. And I want my children, when they're older, to be able to be at the births of their siblings and be a part of that integral part of relationships and families. It starts with the relationship in a couple, and it needs to extend to everyone and be allowed and be legal in this state and in every state. And our state can set an example for those who have not yet followed. This is our opportunity, and we need to take that opportunity now.
All right. Lynn Clark, Kim Strickland, and Karen Ferguson.
Hi, my name is Lynn Clark.
Speak into it.
Okay.
Catch you.
Close. I was doing it because some of the people in the back don't always hear it, except for Tiffany. She's got a loud voice, especially over the music. I'm a home birth mom of one. My daughter is 3.5 years old, and she's running around here today, enjoying all the children in the back of the room. And when I was thinking about getting pregnant, I was in the process of preparing my body by doing some detoxification, by getting rid of all the mercury in my system so that I could have a birth that was good for my child. And in the process, I found out about home births and about midwives. And until then, I did not know that such an option existed. And it was a doula that told me about it that was working with my medical care. She also is certified to do that in a doctor's office. In the process, we talked about home births. We talked about different options that I had, and she informed me that I can go directly to a midwife to find out about home births. And that was a chore. It wasn't that easy, and that's one of the things that hopefully when we legalize home births for the midwives, that we will be able to find the midwives that can take care of us and show us the kind of care that we need. There's so many wonderful reasons to choose a home birth, and they go from prenatal, the minute you walk in their door, to the minute till now, and I'm sure further into the future. I had such one-on-one time with both of my midwives. They consulted me in my nutrition, and they spent large amounts of time. Every prenatal exam was at least an hour. They asked me the minute I walked in the door, "How are you?" And when I said, "Fine," and I meant it, they knew it, and when I didn't mean it, they knew something was going on, and they asked, and they were concerned, and they talked to me about my fears that came from my parents. My parents are both in the medical field. Well, my mom's and dad's in the medical field, and so that's how they believed. They asked me family matters, what's happening in my life, and they were concerned. They came for one home visit to make sure that my home was ready for a home birth and to make sure they knew when the time came how to get there and give us any suggestions to make the birth even better. The prenatal time that they spent with me was just fantastic, and it just carried right over to the births. They spent one-on-one time there. I went into labor on a Tuesday, and my daughter ended up being born on a Friday morning at 5:14, and they were there for the entire time for the active labor pushing, both midwives from midnight to 5:14. Actually, I think they came around 10. One came right after dinner time. They coached me and told me, "You can do it. You can do it." They knew how to give me the support because they had been there with me through so many prenatals. And they also were watching us, making sure that I was physically able to do it, make sure that my baby was fine, make sure that my husband was doing good, helped us to set up, knew how much everything meant to us. And they were there. They also knew enough about me, and they were watching the baby close enough that if I had needed any kind of medical attention, they would have taken me and sent me to the hospital. They allowed for different poses. I tried to have a water birth, but was unable to have a water birth because my body just couldn't do it, so we tried the birth stool, we tried different positions. I was up walking around a little bit, not much. I ended up giving birth on a bed, and they were there helping me. I was comfortable, and I was able to eat. They encouraged me to eat if I was hungry, and especially to drink so I didn't become dehydrated. And the continuity of the environment, to be able to birth there, to labor in my home, to birth in my home, and to keep my child in the home afterwards, was just so special to us. After the postnatal visit, or after the visit, they came to my house twice to make sure that I was okay. I had a slight urinary tract infection, but it was nothing big. I also went to 2 office visits. They were there for me by email, by phone, however I wanted to reach them. And they're still there. They've developed a community for me to meet other home birth moms who respect my choices and understand about attachment parenting and will be there probably for the rest of my life. And hopefully my daughter, whether she ends up choosing a home birth or a hospital birth, these women can support her. And the wonderful thing about giving a home birth is you can do it in your own style. I had 3 friends there. The youngest was 16, and my one friend sang to me during the labor. I had time where I was alone. I had put together a program of how I expected the birth to be. I had an altar of my family that I knew were supporting me. I knew I had a candle there for my ancestors. I had pictures there and special objects that meant something to my family. And what I'm hoping to see out of all this is that women and families, because it's not just a woman's decision, it's a whole family decision, are able to make informed choices. And that we have the option to go to a midwife who can then, if we need it, take us to a hospital and have that interface between the hospital and themselves so that they can stay there and help us even further along in the plan. And that would be most wonderful. And I thank you for your time.
Kim Strickland, Karen Ferguson, Kristen Ripley, and Sister Bedia. Those are the last 4 names. Yeah. But now, is there anyone else? Okay, yeah. So those are the last 4. And what's your name? Okay, Michelle Morrow. And we'll pick up everybody else at the next meeting, just so for time. Michelle, what's your last name again?
I think you wanted to say something. Yeah.
Okay.
I did.
Okay.
Good afternoon. This is my son Callahan, and this is Rory.
Did you want to say something?
Rory got born at home.
Say it again.
Rory got born at home.
Where were you born?
At the hospital because I got stuck. My hand.
He got stuck, that's what he said. I knew before I ever got pregnant and before I ever knew if I wanted to be pregnant that I wanted to have a home birth. I didn't even know if I wanted to be a mom, but I knew if I was going to get pregnant and be a mom, I was going to have a home birth. I met a woman who had 2 children at home, and I didn't even really know anybody that was pregnant that had hospital births, but I just said, oh, that's the way I want to do it. And so when I got pregnant with Callahan, I immediately called around and tried to see about getting a CPM, and I found out it was illegal, and I said, that's okay. I'll just go under the table. That doesn't bother me. It bothered a lot of my family members and a lot of my friends, though. Thought I was doing something irresponsible. I was going, against the law. And but what was important was that my husband and I felt that it was the right choice for our family. And when I was in labor with Callahan at home, I pushed for about 6 hours, at which point my midwives told me they thought I needed to consider transporting because he hadn't moved since the first half an hour. So we went to the hospital. But that was actually the hardest decision I've ever had to make in my life because I was so headstrong that I wanted to have a home birth. And I thought that going to the hospital was going to be horrible. And it actually turned out to be okay, but the main reason it turned out to be okay is because my midwives came with me to the hospital. I was terrified of going to the hospital. Walking into a room of people that didn't know who I was, didn't know what I'd been trying to do, and what I wanted. And they came with me. I later found out that the politics in Georgia had changed between the time when I had Callahan and when I got pregnant with Rory, and that if I was going to go to a hospital, they may not be able to go with me. That needs to change. midwives need to be able to go to the hospital with their patients without being concerned that they're going to get in trouble and, you know, have to go to jail or whatever. They're moms too. I guess the other thing I wanted to say was, nobody asks when you're trying to get pregnant, are you going to be a good parent? Are you responsible? Nobody's there in your bedroom when you're getting ready to make love saying, we want to have a baby, going, oh, what position are you in? Well, that might not be a good position. Maybe you should do this so we can see. But that's what happens at the hospital when you give birth. We should be able to do it our way. When I gave birth, I got to do it my way at home. If I wanted to sit, if I wanted to squat, if I wanted to stand, if I wanted to lay down, I got to do it my way. It's my baby, it's my pregnancy, and it's my body, and nobody else should be able to tell me what to do, especially if everything is fine. Hi. He's fine. I had the same thing. I had so many people tell me I was too small. And when I went to the hospital, that all confirmed it for everybody. See, you are too small. You can't have a home birth. And when I got pregnant the second time, I had to go deep within myself to decide whether or not I was going to attempt it again. And I decided I was strong enough to get through it, and if I had to go to the hospital, I would get through it. And as it turned out, I had the most amazing home birth. He was born in a pool at home. It was calm. He was born at 1. I was in the bed at 4 o'clock. I was asleep. And his brother got to welcome him, in the morning. He slept through the night in the bedroom next door. Never missed a beat. He didn't wake up. And he came in and kissed him on the head first thing in the morning. I couldn't have done that at a hospital. So, this needs to be legal in this state now.
Karen Ferguson, Kristen Padilla, and Michelle Morrow. I'm gonna just say this. I'm gonna have to run. I literally run. I'm convening another meeting. My area is the area where the 92-year-old lady was shot, and there's a meeting at 12:30 that I'm convening. I'm going to have to run, but don't think that because myself or Representative Sheldon may have to leave because she has a 12:30 that we're not hearing it, because it is live on the internet, so we can get the last two speakers, so we will hear you, and we will have the minutes by Sally. So I just want to say that. Thank you.
Okay. I'm Karen Ferguson. Just to let you know a little bit about myself, is that I'm a mother of 4. All 4 children were born at home, 12, 7, 4, and 2. I'm also a doctor of chiropractic and a certified labor doula through the CAPA organization. I'm a member of the Georgia Birth Network, certified in pediatrics, and a member of the International Chiropractic Pediatric Association, which means I'm certified in taking care of children and pregnant women, and a member of the CAPA organization, which is Child and Postpartum Professional Association. Some of the things that were brought up today was just about infant mortality and also about just cost effectiveness, I think, as well. And I think when we take a look at birth, is taking a look at models that work. And I don't think that this piece of legislation would be here today if this wasn't something that worked, or if this was something that was not safe. Talking about that 10% is something that's very valid, that there is a time and a place for emergency situations. However, when you take a look at the cesarean section rate, it keeps climbing and climbing. And that is a real problem that they want to reduce. And the only way I think to reduce that is taking a look at models that work and taking a look at more doing things that empower women. And you take a look at all the statistics that have been shown today in the last 2 sessions, is that home birth is definitely safe. Working with a midwife, you have much, much lower rates of cesarean section, infant mortality, and so forth. Again, this piece of legislation would not be here if babies hundreds and hundreds of babies were dying at home. The infant mortality rate of a home birth compared to hospital birth, there's just absolutely no comparison. And we need to take a look at that. Unfortunately, even in our professional practice, we have many pregnant women that come. And the biggest thing that we get is really they feel like their pregnancy is more of a disaster waiting to happen. I think midwives, even certified nurse midwives, are very frustrated with certain standards in the hospitals and groups that they are involved with, because there's just a certain set of standards that are there. And so as a result, there's more tests and things and so forth that are happening. And so these women, they get very, very frustrated. And being a certified labor doula, I've been to dozens and dozens of births over the last 12 years. And the satisfaction of women who have their babies at home, in the last 12 years, there's only one person who had a home birth. Well, actually, it was a transport. She's the only one person in 12 years that has chosen a hospital birth for the following pregnancy. Everybody else who have had a home birth has consistently had another home birth. I've also known women who've had hospital births and had a very good experience, and I've been at hospital births where midwives were wonderful and it was a great experience. But just from the testimonies that you've heard today, and I was talking to my friend coming down here, like the difference between having a natural birth even at a hospital versus having one at home, it's like the difference between watching TV in color versus in black and white. There's just things that you cannot experience in a hospital that you can at home. And it doesn't mean you can't have a great and wonderful positive experience. It's just being able to have that choice. So taking a look at the issue of infant mortality rate. Being a chiropractor, I was actually going to be a physical therapist, and I think a big issue with what she was talking about is just the misunderstanding or lack of communication between the CMs, the CPMs, the certified nurse midwives, and the OBs. Because even in our own profession, there is controversy, or there's differences of view of opinion, but it's about coming together and really being able to come to a common ground, which is to reduce the infant mortality rate, to reduce the cesarean rate, and to provide a free choice for women. So that's one thing. And then the other thing was even just about compensation and cost. What about for the women who don't have health care coverage? What are they to do? And from that cost-effective standpoint, I know even a couple years ago, a woman who was going to have a birth, and she was going over to Northside, and she was going to have to pay $2,500 out of pocket just for the birth itself. Just for the birth, if everything went fine without any complications or anything like that, is $2,500. And the average cost of a home birth with prenatal care, that one-on-one attention, is around $2,500 to $2,600 for the whole ball of wax. So we really need to take a look and discuss these issues over the next couple sessions. My own personal experience, I couldn't imagine having a birth any other way. My mother has 16 grandchildren. 8 have been born at home, and the other 8 have been born in the hospital. And again, being a certified labor doula as well, is that I've seen both ends of the spectrum, and I've seen midwives, even in emergency situations, be able to know when it's time to transport, be able to handle emergency situation very well, very honorably, and the baby end up being completely fine. And if the baby needs transport or the mother needs transport. And I've also been in a hospital situation where there's been emergencies that have been there, and the baby and the mother end up being fine, but even just the way that the situations are handled are two completely different scenarios. The bottom line is that we want to lower the C-section rate. We want to lower the infant mortality rate, and I really feel that this is the best way to do it, is to start opening the doors of communication, and one way is to legalize home birth. Thanks.
So much. I just want to say something real quick before I head out. I really appreciate you all sharing your testimony, and I do have a couple of questions and I guess maybe a comment. I know it's hard for maybe many of us to believe in this room, but one of the reasons C-section rate is going up is because more and more women are requesting C-sections, and that's definitely something we have to, I think, consider when we look at that rate. And also, I know our first speaker, I definitely appreciate you. Was it Tiffany? No, the blue sweater in the back. Yes. I know you said you had a planned C-section. Is that correct? So Did you have a relationship with a doctor during your pre? Okay. So he was aware that it was okay. All right, good. I wasn't sure if you were, who was planning the C-section.
Surprise.
No. Okay, because you had preeclampsia, and is that not a medical diagnosis?
A midwifery diagnosis too, right?
Okay, so there's no.
It's a complication, but they were in consultation with a physician managing it jointly.
Okay. And and Valerie, is that right? I just wanted to thank you so much for you and your husband sharing. Obviously you're passionate, and I just wanted to, I know you said your mom doesn't remember those first few moments, but thankfully she's got years and years that she's been able to spend with you. And there comes a point when home birth or whatever, there are choices that women have to make, and there comes a point where we have to determine, is it the birthing experience or is the goal a healthy baby? And I think your mom, that was her goal, was to make sure. Right, but in her case with I think you said a ruptured uterus, that may not have been an option, but thankfully she's had years to spend time with you. So, but we are looking at the choice, and I thank you definitely for your passion, and look forward to hearing more from you. But I do have a meeting at 12:30, so I'm late. Thank you. And I think our next speaker, Kristen. Okay.
Hi. My name's Kristen Ribley. I'm a chiropractor here in Georgia. I've been in practice for myself for 10 years. And I'm also a mother of 3. I've had all 3 of my children at home. I was thinking about this on the way down here today, is that with my profession, even with chiropractic, chiropractic was discovered just 110 or 11 years ago, which really isn't that long when you think about it. And it wasn't legal at first. So as people started becoming aware of chiropractic and wanting that as the choice of a health care, it was illegal, and a lot of great chiropractors actually went to jail because they were doing what they loved, what they believed in, and was really helping people. So eventually now, chiropractic's legal. It's become one of the most, it's the number one alternative health care that we have to us available. Helps many people. My practice, we have an emphasis on pregnant women and babies, or children. We adjust and help a lot of people. But I was one of the ones that clapped when we talked about midwives actually going to jail for doing, practicing midwifery. And I remember about I had my first child 14 years ago. And when I was pregnant with him, my midwife had told me that it wasn't, I knew it wasn't legal in Georgia, but I knew that it was going on the floor to be voted on, like we're doing here again. And I didn't think much about it. I just thought, it's going to get voted. Of course, that women should have the choice. And then I got an email again. I'm pregnant again. And I got an email, and it's here we are again, and it's going to be voted again, just to make midwifery, or make it legal for a tradition or a lay midwife to come into the home. And I think the biggest thing here is that what we've all heard, and that so many of us know, is that it can be a really beautiful, safe, incredible experience for a woman. And it really, in my opinion, just comes down to choice. Is that if a woman wants to be proactive in her decision, she wants to educate herself, and she wants to have an experience that's, to her desires, she should have the choice to do that, and not feel like she's doing something irresponsible because it isn't, legal. So I'm here today because, I heard about this 14 years ago and never did anything about it. And so it's my opportunity to at least express my concern. I think that it should become legal in Georgia for midwives to be at home to help a woman. Thank you.
Hello, my name is Ms. Shahid, and I really don't have that much to say. I think midwifery should be legal because, just speaking as a member of the community, I'm not a midwife or anything like that, but I am a teenage mother who was unmarried. You have teenage girls, and I'm one of them, that for fear or whatever reasons, we don't tell our parents or whatever. And if we don't have access to midwives in the community, that increases infant mortality. We have people who are drug users, and for whatever reasons, out of fear of the babies being taken from them or whatever, they're afraid to go to hospitals and, quote unquote, professional places, that if they don't have access to midwives, these babies may become statistics. These are the babies that you see in cans or on the highways where the drug users and the teenage mothers, just out of fear. And I think if we could legalize midwifery, that these people who some people think are throwaway children or throwaway moms because they don't fit the, quote, standard normal what a mom should be, that these women need access to midwifery, where if these midwives are in a community, this is someone who they can feel that they can trust or they can go to and get proper attention and information, where other people may not understand what their situations are. So I think that midwifery needs to be legal so the underserved community of teenage mothers, drug users, abused women can be served without fear. Thank you.
Michelle? No time on Monday. No. Anybody speak now or forever hold your peace? Monday's jam.
Okay. I have 3 children. This is baby, and I have a 15 and a 17-year-old. Both of my older daughters have disabilities, major disabilities. So I was one of those parents that understands what every other mother peripherally is concerned about, the risk factor. Will my baby be healthy? Will everything go well? So when I made this decision, it had to be completely fully informed. I was not going to be taking any risks, and that's why I went with a midwife. My decision was a long, thought-out process, and it ultimately was confirmed when we decided to go to the hospital to do our tour, and they told us that for the first 3 hours the baby was not mine, that it belonged to the hospital. And after 3 hours, then I could be the parent to my child for the rest of its life. I take issue with that. This is my child while in utero, while in labor, after birth, and for the rest of its life. My child, the third one, is healthy. She does not have any disabilities. I don't know that I can attribute that necessarily to home birth or not, but this is a choice that we should be allowed to make. It should be something that we have an informed decision on. Even if we're high risk, we have the right to look at the issues, educate ourselves, and make a decision that is right for our family. Medical treatment should not be mandated. It's something that we should have a right to choose. Thank you.
Is there anybody else that wants to speak? You need to give Sally your name and email address so we get it on the list.
My name is Marsha Jackson, and I recently moved. Well, I moved from South Africa. I had my first son in South Africa in a birthing center, and choosing a midwife was natural for us. It's our option all over the country. So I assumed that coming to a first world country like America, it would be easy. But it wasn't, because I was up in Illinois, and it was kind of hard to get a midwife there. So I figured, well, I'm going to the south. I want to be warmer. I'm coming down this way. And I figured, no, it's not easy this side either. But I find a midwife, and I was moving, and I was coming in between trying to find a place. And I found 2 wonderful midwives that was there throughout my move and supporting me and telling me what I needed. And my hours, they're like everybody said, they will spend an hour with me, whereas at my hospital, my doctor's visit, I will see the doctor for 5 minutes, and that was it. And but I would spend about an hour and a half at the doctor's office. And then for me, it came natural to have a home birth, because my sisters before me in South Africa was born at home, delivered by my grandmother. My grandmother was home birth, my mother was a home birth, so it was just natural for me to want a home birth. So when I came here, I insisted I wanted a home birth, and it was wonderful. My daughter, I was 32 weeks pregnant when I settled down in Georgia, and I saw my midwives regularly, and they knew exactly what I wanted, because my first pregnancy went wonderful because I had a midwife there, but late I had to be induced with drugs, and that kind of upset me because I didn't want to have drugs. And my baby came along, and with the first child I went into pre-labor, which was like a week ahead, and I had little Braxton Hicks going on all the time. But we all thought I was going to be early, and I wasn't. And I came right on a due date, and my midwife actually called me the Sunday when she hasn't heard anything from me. And she called me, she goes, "Are you okay? Are you going to have the baby soon?" And I'm like, "Well, we don't know yet." I told her what my situation was, because I didn't think, I shouldn't bother her, because I'm not used to having a direct line to my caregiver. So I didn't want to bother her with the little small things and stuff like that. She told me, "Well, go lie down and take a rest." And 3 hours later, at 1:45, I went into labor. And it was 7 minutes apart, and I said, "Oh, no, don't call." My mother-in-law told me, "You're going to call right now." And while I was on the phone, and I wasn't sure what to do, she was with me on the phone the whole time. And she was starting my contraction. She was like, "Oh, you're 3 minutes apart. I'm coming right now." And my labor went pretty quick. By 4 o'clock, I was in labor, and I was planning a water birth. But between me going from one place to the other place, I didn't make it to the water birth, but I had the freedom to do it in the position. And I actually ended up giving birth to my wonderful little daughter, Joya, on all fours. And when I wanted to push, I told my midwife, I said, "I need to push." And she's like, "You know what? Just push. Just listen to what your body tells you." And that's all the insurance I needed. And my body took over, and I was in tune, and I just breathing and pushing, breathing and pushing. And for somehow I knew when to breathe and when to stop and when to push and when to not. And that baby came out, and she told me, "Oh, it's out." And I'm like, "I'm done?" And she's like, "Yeah, you're done." And I'm so happy. I was just so happy I couldn't stop smiling. I couldn't stop smiling. She goes, "Well, some mothers, when it went quick, this 2 hours, I'm like, "No, I'm very happy." And that's when I told, and my friends all had hospital births, and my mother-in-law was there, and she had 3 children before that, and she was put out when she got to Rowdy. And she didn't know that childbirth could be that wonderful. She got off the phone, and by the time that baby was born, she had called all the family, because she didn't know that childbirth could be that wonderful. And that my baby came out, and she was strong. She started moving right away and stuff like that. And she didn't know. She's like, "Your baby started moving right away. Why is she so strong? I didn't know." And I'm like, "Well, because your baby was drugged and mine's not." But, and I understand that it's used for drugs and epidurals and stuff like that people want. But if you don't want to have the choice, you don't need to be bullied into a choice that you don't want to have. And I can honestly say that I had a wonderful home birth. I couldn't be happier. I testify to it every time I get. My mother-in-law testified to it every time she gets, because she thanked me for the experience where I was supposed to thank her, because she was there helping and supporting me the whole time. And I just want to say that this should be legal, because it's a natural choice for us to be making. And if anything, just let it be legal, because I want my daughter not to have the runaround like I had, and be shocked because I couldn't just have a natural choice of a midwife. Thank you.
Okay, we're going to try this again. Anybody else? All right, I'm making a commentary here on elective C-sections, and I just want to say that I think if these mothers knew the risks involved with C-sections, with future pregnancies, that they may not be as likely to.
I would like to speak.
Okay. Claire's going to speak.
I was going to give this information to Debbie on the side, but since she brought up that issue, there's a survey called Listening to Women that was done by the Childbirth Connection, which is used to be called the what used to be called? Doesn't anyone know? Anyway, it'll come to me in a minute. That's estrogen deficiency. So anyway, this is the second time they've done it, and they surveyed a couple of thousand of women throughout the United States about what happened to them during their pregnancy and birth. and what experiences they had, what technology they had, what choices they made. And it's a myth that women are asking for cesarean sections. Of that survey, which was standardized, only one woman admitted that she made the choice of request for a cesarean section. The other women are feeling coerced into cesarean section. So I know that women want a lot of things that aren't necessarily the best for them, but I think that to attribute the C-section rate to women asking and demanding C-sections is a myth. Thank you.
Sure. We'll make sure they hear it. They've got this. It's in their packet that I gave them. One thing I want to let everybody know: we have 2 more meetings. We have 2 more meetings. Next Monday should be a really interesting meeting. The folks from Medicaid are going to be speaking. I believe the director of the OBGYN Society, or the president, had somebody, OBGYN Society, be speaking. Somebody from the Hospital Association is going to be speaking. And Marsden Wagner, who is the former director of Women and Children's Health with the World Health Organization, is going to be speaking. So it's going to be, yes. Everybody here, bring your friends.